Hi, I'm Brittany, a neurodivergent mum and speech pathologist. This is Not Just Theories, where I share what actually works in my real, messy life. Because life doesn't follow a theory. Here's what I actually do. Hello, everyone, and welcome back to Not Just Theories. Last week, we were talking a lot about advocacy and trusting your instincts, asking questions, and how to gently push back when something doesn't feel right. Today, I'm going to go deeper into a specific area that parents often encounter repeated wait and see responses, or they often get stuck without a clear path forward. And that is childhood ENT issues, ear, nose, and throat issues like ear infections, hearing concerns, snoring, mouth breathing, sleep disordered breathing. So this episode is for parents who are noticing patterns in their child that aren't going away, that are potentially impacting their sleep or their speech, or something just doesn't feel right, and they want to know what to watch for, when to ask for a hearing test or an ENT referral, and how to prepare when you do. So I want to note I am not providing any medical advice in this episode. What I would like to provide is some basic education about common ENT issues and possible pathways forward. So this is the same information that I regularly provide to my friends and my clients if they come to me with concerns about their child's speech and language development or their child's sleep. Why are ENT issues so important in children? And it's because kids aren't just small adults. They actually have a different anatomy. They have smaller ear drainage tubes. They have a differently shaped skull that makes them more likely to experience ear infections, whereas with adults, because of the shape of our skull, we're more likely to experience sinus issues. So often children, especially under the age of about 6 or 7, the way their ear tubes are in their skull is flatter. So they're less likely to drain, whereas as we grow taller and our skull shape changes, those ear tubes become a little bit more diagonal or vertical, and they're more likely to drain properly, and as well as just becoming bigger. Likewise with the back of our throat, the size of tonsils, children's mouths are so small that inflamed tonsils or adenoids can take up more of their airway and more of the back of their mouth. So that's sort of a reason why childhood ENT issues are more common than you might expect. It's because of the anatomy of children. So problems with their ears and nose and throat can affect hearing and therefore their language and speech development. They can affect the sleep quality. They can affect a child's behavior and attention. They can also affect a child's feeding and growth. So even mild or normal symptoms, or symptoms that some people might say are normal, can actually cause a real functional impact. That's why there's a lot of specialists out there. One of them that I often recommend people look at the resources he provides is Dr. David McIntosh. He is a pediatric ENT. He has extensive training in children's airway issues and middle ear disease and facial and dental development. And he really emphasizes the importance of empowering parents to recognize early signs and advocate for a referral when needed. So we talked a little bit specifically about advocacy last week, but I would like this episode to really empower you that if you're noticing any of these concerns in your child, to give you something to take with you to your GP appointment to really advocate to see a specialist, an audiologist or an ENT about your concerns. Because, like I said last week, the best case scenario is you go to that specialist and nothing needs to happen. But if you don't go and something did, then there's a real risk there. So I'm going to tell you a little bit about some really common childhood ear, nose, and throat problems and what they might look like. The first one that I want to talk about are ear problems, specifically glue ear or middle ear infections. And the reason I'm talking about that is because it is one of the most common ENT issues for young children. So it basically means that in the middle of your child's ear, there is some fluid that doesn't drain properly. So if that's really actively infected, that might cause pain, or it might cause an eardrum to burst. But sometimes without like an active infection, that fluid could still sit there, and it's called glue ear, and it doesn't drain. And all of this can impact on your child's hearing. Some red flags that your child might be experiencing glue ear or otitis media. Things like recurrent ear infections, where you actually actively are aware of the ear infection because of symptoms like fever, or you go to the GP and they tell you that your child's eardrum is red, or you need antibiotics. Persistent fluid behind the eardrum doesn't tend to have the same outward signs like the fever and the red ears. That might be more when you're noticing that your child's hearing just is a little bit off. So your child might not be responding consistently to soft sounds. They might need the TV or other appliances volume louder than other people. And you might even notice behavior changes in your child, which might improve when ear fluid clears. So glue ear, in and of itself, if it's short term, like if it only happens when your child is actively unwell with a cold, might not be a concern. But if glue ear persists for months and months, that's when it can often start affecting your child's hearing. And once it's affecting your child's hearing, that's when it can affect their speech and language development. And that's when it's really beneficial to see an audiologist or an ENT to monitor and discuss whether there needs to be an active management plan. Hearing issues can be caused by other things other than ear infections and other than glue ear. I'm not going to be talking too much about those today because hopefully in Australia, those types of issues tend to be picked up at the newborn hearing screening, which is something that happens within the first few days of a child's life in Australia in the hospital. They come around and they check whether there are hearing issues. These issues tend to arise later in a child's life, often once they start meeting other people, starting to get things like colds and flus and viruses, often once they start daycare. So those kind of issues like glue ear infections, they tend to often have a more viral cause to begin with. And those ear issues can lead to hearing issues. And some signs of that on your child might be that they're not responding reliably to their name, perhaps if they have done so in the past and then they don't do it anymore. They might have trouble understanding you when there's a lot of background noise. They might need you to repeat yourself multiple times or speak more loudly. Their speech might seem delayed or unclear compared with their peers. There are actually some really specific speech warning signs that are less common errors that are much more common when there's a hearing issue. So I'm going to talk about some of those in a moment. But if you start seeing those signs, even if there is no pain or fever, a formal hearing test is a really practical first step. And that can be done before or in parallel with an ENT referral. As a speech pathologist, I'm often the first professional a child might see if there are concerns about their comprehension or their speech pronunciation, and I always recommend a hearing test, ideally to be completed before the child even sees me for their speech and language assessment, if timelines permit, if they can get in to see an audiologist quickly enough, because unfortunately in Australia, there is no scheduled hearing check after that initial newborn hearing test in hospital. And so many parents are not aware of this. They often tell me that their child's hearing was tested at one of their blue book checks with a nurse or a GP. But actually, a formal hearing test is not the same as having a GP look in your child's ears. And it involves specialized equipment that's not present at a regular blue book check. So I would love for there one day to be a scheduled hearing test for all children during those toddler and preschooler years. But until that day, parents do need to seek out and pay for a formal hearing test on their own, which is a real shame here in Australia to not have that covered by Medicare. You can often get a rebate if you have a referral, but it really depends on the specific audiology service or ENT service, whether that rebate is available. So it is something I recommend to everyone, but I know it can be quite a financial stretch. Some areas might have a nurse audiology service available, so it's always worth checking with your local community health centres if they happen to have a nurse audiologist available. Often that has an age requirement, so it might be only for children older than a certain age, because the test for children under about 3.5 is different to the test for children who are older than that and does require slightly different tools. I think it's really important to know that there is no formal hearing test other than that few-day-old newborn screening in hospital, because so many parents just think there is a hearing test done at one of those blue book checks. Sadly not. I'm just going to talk now about some of the sound errors that you might notice if your child has a hearing issue. This list that I'm going to read out now is on the Banter Speech website. I'm going to put the link in the comment section if you would like to read through it. So some of the patterns that we're looking out for are whether your child uses hissy sounds instead of other consonants. So that's if they use sounds like s or sh or f instead of sounds like n or or d. So using those long hissy sounds instead of other consonants. Another common one is if your child leaves out the first sound in words. So that might look like saying ig for pig and just getting rid of that p sound. It's really, really common for children to delete the final sound in words, and that is a normal part of typical speech and language development. But leaving out the first consonant in words entirely is less common and is often more of a sign that there might be a hearing issue contributing to your child's speech and sound issues. Leaving out the middle sound in words, so if it's a 2-syllable word like bottle, they might say bowl, and just not say that middle sound. If your child adds sounds to the end of words that aren't meant to be there, so if instead of saying the word for, they say forn or fort, and they're adding extra sounds, that can be a real red flag that there might be a hearing issue underlying. If your child moves sounds that are meant to be at the front of their mouth to sounds at the back of their mouth. So, for example, instead of saying tie, they might say kai or guy. So this is called backing, and it is unusual. It is far more common for children to do the opposite, which is called fronting, moving sounds from the back. Instead of saying kitty cat, they might say titty tat. That's very, very common, and that is not a sign necessarily of hearing issues, but the reverse, using a k or a g sound instead of a front sound like a t or a d or an n, is unusual and might be a sign that there are hearing issues. Adding glottal stops to little syllables. So instead of saying bottle, they might say bottle. And it could be described as speaking with like a Cockney accent. So sometimes that's how parents actually describe this child's speech sound errors. They sound like they've got a Cockney accent. And what they mean is that they're using that sound right at the back of their throat instead of other sounds like a t. Some of the other errors can be tricky to distinguish from typical phonological processes or common speech sound errors. So that might be things like getting rid of k and g sounds in clusters. So instead of glass, they might say las, but that can also just be a developmental thing. So it goes into a bigger picture rather than being a standalone one. Or it might be if they get rid of that final sound in a word. Again, that can be a typical part of development, but it might be a sign that the hearing is an area of concern. If your child says sounds really softly, so instead of saying pin with that like real airy, puffy sound that comes out, if they just say bin without that puff of air, that could be a sign that the hearing is a concern. Gosh, there's a lot of them on this list. I will put it in the link for you all to read through. If instead of saying ch, your child says a sound like t instead, or if instead of saying a j sound, they might just say d. Again, that can be a typical developmental speech sound error, but it can also be a hearing-related error. And then the other thing that can often happen if a child has hearing issues is that when they speak in sentences, it's almost like they mumble or everything's a little bit fuzzy or just not quite clear, but there might not be a consistent pattern like a specific sound error. So some of these are really hard to tell apart from typical developmental speech sound errors. But some of the things that in that list, if you are noticing it in your child, even if it is a sign of typical language development or typical speech sound development errors, we always recommend a hearing test. It is a non-invasive test for children to do a hearing test, particularly if they get something called a tympanogram, which is just a little puff of air going into their ear to test whether there is any fluid behind their eardrum. It's really quick and easy to get just that test done, even if your child won't cooperate with like pointing or looking in the direction that they hear a sound or pressing a button when they hear a sound. Even if your child can't do that sort of behavioral component of a hearing test, the tympanogram where you get the ear pressure test, is there fluid behind the eardrums, is such a valuable tool and really, really quick and easy for most audiologists to complete, even with really, really young children. Another thing that can be a red flag that I often recommend parents start seeing an ENT for is if there are concerns about their child's sleep. So particularly if they notice that their child is snoring when they're not unwell. So many kids snore occasionally when they've got a cold or something to block their nose. But if that snoring is persistent or accompanied by really disrupted sleep, that's when it can signal that there's something more. What it often ends up being, not always, often, is enlarged adenoids. So adenoids are a tissue that's located sort of behind the nose in the airway that are meant to help fight infection. But if they get enlarged or inflamed, they can block the airflow through the nose. So this often looks like a child who might mouth breathe most of the time, who might have loud or frequent snoring. They might have pauses in their breathing while they're sleeping, or very restless sleep, so they move a lot, or they wake up gasping or sweaty, or often waking up tangled in the sheets. Or it might look like daytime tiredness or irritability or behavioral concerns. They can actually cause symptoms that are suggestive of ADHD when it's an underlying airway and breathing issue. So this is a real impact on your child because it affects how much oxygen they're getting to their brain. And that mouth breathing is often their way of trying to compensate for it. And it comes with its own issues. So often a child whose mouth breathing will still be drooling beyond the age where you might otherwise expect to see drooling sort of start minimizing. They might wake up with a really dry mouth, a really bad breath, and basically mouth breathing, except when a child is like actively unwell with a viral infection, a respiratory infection, is a concern that is worth seeing a pediatric ENT about. Other ENT related symptoms that you might notice are having a really frequent runny or blocked nose, that mouth breathing, chronic congestion, persistent throat clearing, repeated tonsillitis or throat infections. And none of them alone necessarily might be a problem, but those patterns where you're noticing more than one of those things happen, or you're noticing one of those things happening more of the time, really matters. So when should you seek a referral to an audiologist or an ENT? It can be super tricky to know when a single symptom warrants referral. But I have a list of symptoms that were put together by the ENT I referred to earlier, Dr. David McIntosh, that many clinicians I work with get parents to circle anything that they're noticing, and you take that list with you to your GP to help you discuss with your GP whether or not you need a referral to an audiologist or an ENT. Basically, if you notice any speech or language concerns in your child, it is worth seeing an audiologist for a hearing test, at the very least. I think it should be a required pathway before seeing a speech pathologist for speech and language and communication concerns. Separately to that, if you notice any of the following: snoring most nights, mouth breathing during sleep or during the day, pauses in your child's breathing or gasping or choking at night, recurrent ear infections, not responding reliably to sounds, especially soft sounds, speech delay, unclear speech, or behavioral symptoms that are worse after your child's had a cold, any of those things, it's worth taking that to your GP and asking for something specific. And that for me would normally be an audiology test if you're thinking that it might be more a hearing concern, because that might help you then advocate to see an ENT. If you can get straight to an ENT, amazing. Many ENTs actually have an audiologist that they work closely with, and they'll send you to the audiologist in their practice, and then they'll see you, and it's all in one place. That can be really convenient. But some GPs like to start with an audiologist referral, and then if their hearing test shows any concerns, that's when they'll give you an ENT referral. That's fine too. That's a great pathway. If you're noticing the snoring side of things and the breathing, or if you're concerned about those adenoids, you really should just go straight to the ENT. I really, really strongly recommend it. GPs will often give wait and see advice. If they give you wait and see advice, please make sure that there is a really clear plan of how long you're waiting for, what would prompt your revising that plan sooner. So if your plan is let's wait 3 months and then until the end of winter, for example, and then we'll do a hearing test, or then we'll see an ENT, ask your GP what would warrant a sooner referral. Is there something that would cause you to not wait that 3 months across winter? And really thinking about, what is that wait time relative to your child's age? If you have a 12-month-old and you are concerned about their speech development, and you're concerned about that might be because of their hearing, and you need to wait 3 months to see an audiologist, or 3 months for a referral to see an audiologist, that's a quarter of your child's life again before you're even getting any assessments done. That is a huge amount of time in the life of a 1-year-old. If you have a 6-year-old and you think that your child's been complaining about not being able to hear properly for 5 days and they had a cold last week, that might be a situation where waiting and seeing if that blocked ear goes away on its own after a couple of weeks might be more appropriate. So the age of your child and what the specific symptoms are and when they started all make a different picture. I think what I really want parents to come away from this episode with, though, is knowing that it is okay to ask to see a specialist, audiologist, or ENT. Once you see an ear, nose, and throat specialist, if you do have persistent hearing issues caused by glue ear or regular recurrent ear infections, or you have sleep disordered breathing caused by enlarged adenoids, there are a few options available to you. So sometimes that might look like a nasal spray, like a Nasonex, to see whether that can help reduce the inflammation of the adenoids, and that might actually also help with hearing. So because the adenoids, when they're swollen, can actually also block off the drainage tube from the ears, enlarged adenoids can also be really strongly associated with glue ear, and treating the enlarged adenoids can affect the glue ear. So a conservative management might be something like using a nasal spray to see if that clears up the glue ear or enlarged adenoids. If that fluid persists and is really significantly affecting your hearing and speech, if the enlarged adenoids are blocking the airway a lot and disrupting the sleep, your ENT might recommend you go straight to surgery as an option. So it's not a cosmetic procedure, because this really improves your child's hearing and speech and their access to language and their sleep quality and their behavior and the quality of life. But what the surgery looks like is, for the hearing issues, it looks like grommet insertion. So we call them grommets in Australia. They're called ear tubes in other places like the US. And they're basically little tubes in the eardrum to allow the fluid to drain out of the ear instead of having to drain through the little hole in the back of the throat. And that allows air to go into the middle ear. So that can improve hearing, and it can reduce the number of ear infections or how long they last for, and can really get rid of all of that buildup of fluid and gunk in the middle ear. Something else that the ENT might consider if your child has enlarged adenoids is something called an adenoidectomy. So that's the removal of the adenoid tissue, and that's usually when it's chronically enlarged and is significantly obstructing nasal airway and contributing to sort of persistent mouth breathing, or contributing to those persistent ear problems. There are a lot of really common questions that parents ask me as a speech pathologist, and I'm sure that you take these also to your GP and to any other specialists. These are ones that parents often ask me, and this is the advice that I've received from ENT trainings that I've attended. The first question is, Is snoring normal? And the answer is occasionally. It can be very common, but any regular snoring paired with restless sleep is worth checking further, particularly in children. My child has a lot of colds. Should I worry? Well, kids do get viruses, but if their symptoms persist between those illnesses, or the illnesses recur so frequently that those blocked ears happening when they're sick is majority of the year and it is impacting their speech and language development, that suggests that it's worth seeing an ENT. So even if that glue ear is only when your child is actively unwell, if your child is actively unwell for a significant portion of the year and it's affecting their development, it might still be worth having those grommets put in, even if your child's ears naturally drain between illnesses. So that's a decision to be made together with an ear, nose and throat specialist, and not necessarily any other professional. But the child having a lot of colds in and of itself, if they're otherwise well, symptoms aren't persisting, there are no impacts on the development or attention, that might be a different pathway. And then that last question of just, what if we're just told to wait and see? Ask for specific timelines. Ask for what the red flags would be that would change the plan. And ask if you could just see an audiologist to get a hearing test in the meantime, so that you have objective information the next time you see your GP. So even if they won't refer you to an ENT, ask if they will refer you just to an audiologist. When I say just to an audiologist, that is still a medical specialist. I don't mean to denigrate that profession in any way. They're often just a little bit quicker and easier to get into, and it's often easier to persuade GPs to give a parent an audiology referral than an ear, nose and throat referral. But once an audiologist has detected hearing issues, you've got evidence in your hand from another professional that you can take with you to advocate for an ear, nose and throat appointment. So if you're thinking about asking for a GP appointment, so asking your GP for a referral to an ENT, my advice would be to take a written checklist with you. I will link in the comment section to the one that I use. Bring notes about when symptoms started and how often they occur and what the impact is that you're concerned about on your child. Are you concerned that it's affecting their speech and language development? Are you concerned that it's affecting their sleep quality? Are you concerned that it's affecting their behavior during the day? Ask for specific outcomes and maybe even have these questions written down. What extra information would a hearing test give us? What would make you refer to an ENT? What symptoms would prompt a referral sooner? And if possible, make these appointments with your GP for a time that you're as well rested as possible, because keeping on top of those nuanced details do really matter. So in closing, ENT problems in children are really common, but they are not normal if they are persistent, if they're affecting your child's hearing or their sleep or their speech or their behavior. Patterns matter more than single symptoms, but single symptoms over a period of time matter too. Having a clear pathway, whether that's GP referral, hearing test with an audiologist, and then an ENT assessment, can make a really huge difference in a child's development and daily life. So advocating as strongly as you can for that pathway to be followed is really important if your child has any of these symptoms. So I hope this has been helpful. And next week, we are getting ready to start a deep dive into infant sleep, which is something so many parents struggle with and is something that I feel, although I'm a speech pathologist and I'm not a trained pediatric speech specialist, I have read so much about infant sleep and done so many trial and errors with both of my children that I feel like I just want to share my experiences, some of the things that have been helpful and less helpful for us, and just raising awareness of all the different pathways available, because there's so much out there when your child is having concerns about their sleep. There are so many things that could be contributing. And I'm so really just going to do a bit of an education series focusing on some of the different areas that we had to address with my child's sleep before we were able to come to a point where we were all getting the rest that we needed. So it's going to probably get a little bit personal and will hopefully provide just some ideas for things to investigate further if you, like me, have a child who can't sleep for longer than 20 to 30 minutes in a row. So it's going to be probably pretty intense, and it's probably going to take a few episodes to explore that, but I'm really looking forward to it, and I can't wait to talk to you next week. Thanks so much for listening to Not Just Theories. I really appreciate you being here. If this episode resonated with you, the best way to support the show is to follow, leave us a rating or review, or just share this episode with someone else who you think might find it comforting or useful. I hope to see you back here soon.